Well, my name's Sydney. I race women's professional motocross. I love everything about motocross. Like jumping. There's never a dull moment when you're riding. Every lap there's something different that you didn't do the lap before. Nothing's ever the same. I went off this jump and a guy came up behind me and I didn't even know he was like behind me, and I went off of it. I was going into this corner and he came up and he just T-boned me. And then I crashed, and when I crashed my shoulder just like went back like that. I landed on it like that. About 2 months later it started slipping out of place. And so that's kind of when I figured that something was wrong with it. But my dad told me that it was fine. So I went and I raced my first pro national, and I crashed again on my shoulder because it slipped out of place. You have to have a lot of strength and endurance to be able to control a 200-pound bike. The tracks are always really rough. So, you're coming into braking bumps and you have to be able to get your bike to settle down into them. And if you're going off a jump and your bike goes sideways, you have to be able to kick it backwards so it's straight when you land. And that's also some of the main problems that I've had with my shoulder. I went off a jump and I couldn't work out to get my shoulder. I didn't have the strength to be able to control my bike, and I'd go off a jump and I'd get kicked sideways, but I couldn't bring it back because I didn't have the strength to do it. And that's kind of when my dad told me that I was done until I had it looked at.
Sydney Babcock is a patient who showed up in my clinic, and here's this girl who's quiet, a girl, she barely looks like she's old enough to know how to drive, and turns out she's this high-level world-class motocross racer.
He's never raced motorcycles, but Dr. Chris Wall knows athletes. He's a UW Huskies team physician and an orthopedic surgeon who treats his patients at the University of Washington Sports Medicine Clinic.
She'd had several shoulder dislocations while riding her motorcycle, and multiple crashes that had resulted in bone loss from the back of the humeral head. We'd discussed the different options that were available to try and stabilize her shoulder. One of the critical things for her, I think, was to get back and race, and to get back at a reasonable time, because she's at a point in her career where she was about to or had just turned professional. And so it was very key for her to get back and ride at that high level, but of course she had to have a stable shoulder to do it safely.
Oakley, go get it.
When people dislocate their shoulders and they're out for a long time, or they've had many dislocations, being out will cause the front part of the socket to grind a hole in the back part of the articular surface. So instead, where you would normally have a surface area that comes all the way out to the edge here, you've got a missing surface area where my finger is. The problem with that is that even if you fix the ligaments, there's a certain range of motion in which that defect is going to find the front of the socket, and the shoulder will continue to dislocate. So even within relatively small motions, the shoulder keeps dislocating.
Dr. Wall has developed a surgical procedure that addresses the bone loss patients experience after repeated shoulder dislocations. After a consultation with Dr. Wall, Sydney and her parents discussed the possibility of choosing this relatively new technique.
He wanted to know, was she willing to take this chance? We knew going into it that there wasn't that many that had been, put through this. She was willing to do it, knowing that there was that chance that this was going to solve her problem.
Dr. Wall's procedure, called the daisy graft, is the result of the painstaking process that's involved in developing a new procedure. As a UW physician, in addition to seeing patients and performing surgeries, Dr. Wall works on perfecting new techniques that improve patient care. The daisy graft procedure is different from what surgeons have been doing for years to stabilize a dislocating shoulder.
Traditionally, what we've done to try and fix this is, because this is a relatively hard place to get to in the shoulder with open approaches, we've tried to fix it by adding bone to the front of the socket. So if you imagine, if I add more surface area where my fingertip is here, even if that defect finds the front of the socket, the shoulder still can't dislocate. But that's not a very anatomic approach to the problem of there being missing bone here.
The goal of an anatomic repair is to restore the patient's normal anatomy. In the daisy graft procedure, Dr. Wall drills holes in the head of the shoulder bone. Then he inserts synthetic bone plugs into the holes. This restores the surface of the shoulder head to its normal shape. This procedure is performed arthroscopically through small incisions, using a camera to see the inside of a joint and guide the surgeon's instruments. Recovery time is shorter compared to open surgery, and there's minimal scarring.
She came out of there with, I think, 5 little tiny holes and no stitches, nothing. It has been probably the best choice for her to be able to do what she enjoys, and not having 6 months of recovery and a huge scar. And the recovery was really, really fast considering what she had done. Sydney was really a good little patient. She really was. She really did follow the guidelines that Dr. Wall had set for her, because bottom line, she wanted to go back and race this summer.
I'm really happy that I had the surgery. I mean, my shoulder feels so much better. Like when I'm riding, I have the strength now and it's not slipping out of place, and I feel like I'm more comfortable on my bike because I'm not afraid that my shoulder's going to slip out and I'm going to crash.
The surgery that repaired Sydney's shoulder is still relatively new, but her shoulder wasn't the first one that Dr. Wall repaired with the procedure. That honor went to Eric Ogard.
So what do you guys want to do?
I want a bat.
You want a bat first?
Yeah, bat first.
You guys want a bat?
Yep.
Am I pitching?
Eric's right shoulder problems began years ago.
I dove into a swimming pool and my arm came out of the socket and immediately popped back into the socket. I didn't really know what it was, but in retrospect, I know that's what it was. And there was probably a couple years where nothing happened to me. And then one day in high school, while playing basketball, I went up and blocked a ball and my arm came completely out of the socket and stayed out of the socket. At that time, I went to the emergency room. They put the arm back into socket, and then I went through some physical therapy for a few weeks.
There's some Ritz in there, guys.
And then over the course of 4 years of college, even while being an athlete on the soccer team, I would have my arm come out of the socket and put it back in. And through the years, it became looser and looser and would come out of the socket more frequently for very unusual reasons. I've thrown it out sneezing. I've thrown it out playing tennis. I've thrown it out sleeping. I've thrown it out while skiing. And if I had to estimate over the period from 1983 up until about 2 years ago when I had the procedure, my arm probably on average came out of the socket 10 times a year. And on 2 occasions, I had actually gone to various orthopedic surgeons to ask them, what should I do about my arm? And, I heard different opinions about what I could do to treat the dislocating condition, but I always felt uneasy about the fixes that were being described to me. Okay, Matt, let's have you bat first, then Grant, and then Abby. Sound good?
Yeah, sounds good.
When he came to me, we got studies. We had an MRI performed and a CT scan that showed that he'd torn the ligaments at the front of his shoulder that keep the ball stable in the socket. He'd also had one of these larger bone defects in the back of the shoulder. And so the only option that sort of existed to treat this would be to take a bone graft from his hip or elsewhere in the shoulder and to add more bone to the front part of the glenoid socket to try and keep the shoulder stable. The problem with that procedure is that, again, it's a non-anatomic procedure. We're basically making the anatomy of the shoulder even more abnormal to try and compensate for the abnormality that was really causing him to dislocate repeatedly. What I'd talked to him about doing was trying a technique that we'd worked on in the lab that would allow us to put a surface area back into the region where the bone was missing in the humeral head, and also repair the ligaments so that he wouldn't have this problem with dislocating over and over again.
The procedure appealed to Eric. He'd considered surgical options before, but hadn't felt comfortable with traditional techniques.
When I saw Chris for the first time and he described what he would do, he used this phrase, anatomically correct procedure, where we return your arm to its original state. that sounded great to me as well. Very different from the 2 prior procedures that I'd heard about.
So we're switching sticks.
This was the repair technique that Dr. Wall had been developing to restore the surface of the shoulder head. He'd been researching the technique and performing it in his lab, but had not yet performed the surgery on a patient. After years of waiting for the right surgery to come along, and after thorough discussions with Dr. Wall, Eric was ready to give it a try. He understood that he would be the first patient to have the daisy graft performed, but he knew that it was the product of a long and methodical series of careful steps.
While this procedure was progressive, because I was the first one to get it, I didn't feel concerned about that at all, because I felt like, well, one, if you look at Chris's credentials and his experience, it's truly world class. And if you listen to him describe the anatomy, he's actually quite conservative. So it's progressive procedures getting us back to more of a normal, natural state, rather than doing something anatomically radical. And that just resonated with me.
I think it is a leap of faith on any patient's part if they're going to be undergoing a procedure that's different than what's the accepted standard of care. I felt quite confident that we were doing something that we had all the bugs worked out on, and we were doing something that wasn't a big step from things that had been done before. So I felt very confident that what we were offering Eric was actually better than what existed there before. And we'd had opportunities to work on this procedure and check its efficacy in the lab before we ever considered doing it with Eric. The arthroscopy lab is an environment where we have all the instrumentation and equipment that we do in the regular operating room, but instead of working on patients, we're working on donated organs. It's an environment that's very, very similar to the real surgery, with the anatomy and everything exactly the same as it would be in the operating room, but there's no risk to causing damage or to damaging someone's health.
Eric has had great results from his surgery. He reflects on how life would have been if he hadn't gone ahead with it.
I either would have had a shoulder that I just continued to suffer with and let it come out of the socket and, you know, deal with the issues there, and probably had a terrible case of arthritis by the time I got into my 60s and 70s, or I would have had a fix that would not have allowed me the range of motion in my shoulder, the natural flow and function that I currently enjoy today. So it's returned, you know, my body's condition to something that I remember from my youth, and I'm extraordinarily grateful for that. Guys, you coming in?
Yeah, I think so. Let's take a couple.
The innovative surgery performed on Eric was developed in an academic medical setting that supports ongoing research. Ultimately, that research directly affects patient care. Here in UW Medicine's Institute for Simulation and Interprofessional Studies, or ISIS, models can be used to develop new procedures. Simulation technologies are available to teach a new generation of physicians, and experienced surgeons can practice new techniques.
It's a place where we can develop and perfect surgical techniques that are new and exciting, but do them in a very safe, controlled manner where no patient is going to be harmed in any possible way. We're working on plastic models, and we get the technique down perfectly. And then we're ready to practice it on a cadaver. So the development of a new technique and the discovery of newer and better ways to take care of patients is what ISIS is all about.
At the ISIS facility, medical professionals can work with the most sophisticated simulation equipment, or in some cases, on the simplest models, like this one that Dr. Winston Warme built himself. With this large-scale model, it's convenient to visualize one part of the shoulder's anatomy, and it's big enough to demonstrate procedures to others. Dr. Warme is an orthopedic surgeon specializing in shoulder and elbow problems. When he's not